Howdy, y'all. This is Jeff, and I'm going to share with you a presentation I gave to the 2013 Medical Director track at the Texas EMS Conference. This was one about PPAPs. PPAPs is a acronym that I came up with about 5 minutes before I started talking at this conference. And PPAP stands for Potentially Practice-Altering Papers. And these are the ones that I used in coming up with our SSCs. So in general, when I gave this presentation, I wanted to share with them the format that we were going to address to talk about each paper. And just in case you're already bored with that, I'm going to move on fairly quickly. These are the topics that I shared with the folks there at the conference. And if you'll look at this, you may notice combative patients and seizures, intubations, backboards, CPR. These are the things that our medicine that we do a little differently than other places. And I have said that I like to be evidence-based. And I think in those places where we may differ from what most EMS systems do, we differ because of research. And I just want to share some of that research with you. In this podcast, we're going to talk specifically about combative patients. So this paper is called Randomized Controlled Trial of Intramuscular Droperidol versus Midazolam for Violence and Acute Behavioral Disturbances. The DORM study. Wow, that is one really, really long name. You know, I subscribe to the get the meat of your study, the point of your study out in the title of your paper. So if these folks had listened to my approach to doing papers, and this is actually something called the Bucata rule for a guy who does a lot of podcasting on emergency medicine abstract. Basically what he would say is this is the droperidol is as effective as midazolam or a combination of droperidol and midazolam, but much safer. That's what he would call it. Just as effective and safer. So let me tell you a little bit about this study. Basically, this was an Australian study, and it aimed to answer the question, what is the best agent for sedation in ED patients? So the population they were looking at were emergency department patients with undifferentiated violent agitation. These patients specifically needed physical and chemical restraint, along with great big burly security guards sitting outside of their door. These folks were, it was done in Australia, specifically it was an urban Australian emergency department, relatively busy for the time period. It was between August of 2008 and June of 2009. And what they consider to be relatively busy is about 27,000 visits a year. And to put that in perspective, that's what we see at Scott and White Emergency Department in Round Rock. The Scott and White Emergency Department in Temple sees right at 100,000 a year. Apparently, Australia is a great place to practice if you're an emergency department doc. The population here, undifferentiated patients. So these are drunk patients, they're drug overdoses, they're psychotic patients. They're the patients we see. When we see someone who is out of control, combative, we don't know why they're out of control or combative. We just know that they are out of control and combative and they need to be calmed down. So all patients, specifically all adults. There were some exclusions, and I'm going to switch over to this next page here. And this shows the flow of patients through the study, basically who got included, who got excluded, how many went into which groups. So the exclusions were, you see some of them right up there at the top. The biggest of which is they were able to be talked down. They did not need the physical and chemical restraint after de-escalation. So these were adult patients, anybody over 18, and these were patients that were not able to be talked to, they couldn't be reasoned with, and there was no way that they would agree to voluntarily take oral medication or allow you to start an IV in them. So completely out of it. These also were excluded if EMS gave them any sedation. So what were the methods of this study? This was a randomized, prospective, double-blind controlled trial. So this is as good as literature gets. This is the gold standard of literature. So the intervention, they assigned these patients to one of 3 study drugs. So there were basically boxes that the doctors would open. They would say, this patient needs sedation. We have to do something to calm him down. And they would go and open up a study box. The study box had no labels on it other than an A, B, or C. They had no idea what the label meant. And there were actually 2 syringes in the box. And they would give each patient both syringes. So 1 shot in the left arm, 1 shot in the right. So in one set of these syringes were 5 milligrams of droperidol in each syringe. So the droperidol patients would get 10 milligrams of droperidol, just like our practice is. Another group, the comparison, would get 10 milligrams of midazolam. So 2 syringes full of 5 milligrams each, 10 milligrams of midazolam, which you'll notice is a pretty big dose compared to certainly what we used to use, and I think what most people who still think midazolam is a good approach to combative patients use. The other thing they used, which was kind of interesting, was a combination of droperidol and midazolam. So 1 syringe had 5 milligrams of droperidol, 1 had 5 milligrams of midazolam. And the thinking was that this would lower the amount of both agents and provide just as good a sedation with fewer side effects. And then as you look through here, you can kind of see the markers here. Additional sedation, need for additional sedation. That's one of the primary outcomes. And then adverse reactions. So their primary outcome was the duration of violent behavior. And the way they timed this was how long security had to be at the door. Some secondary outcomes, really, which were more important to me, were did they need to give additional sedation? Who got hurt? Were there any further evidence of violence or incidences of violence, and were there any adverse reactions? So let's take a look at the primary outcome, and that was the duration of violent behavior. And let me just explain this chart a little bit. Basically, on the y-axis you have time, and on the x-axis you have each of the groups. And each one of those dots in the droperidol picture, for example, this is a scattergram, and it shows where each patient ended up. So you can see there was one patient who needed, it took him about, 95 minutes to get sedation. And then you saw there were some that got sedated in 4 minutes. The line marks the mean, so the average sedation for droperidol was right at 20 minutes. You can see it was a little bit longer for midazolam and a little bit longer still for the droperidol and midazolam. All right, so what if, in the paper they actually show that there's a p-value for this. The distinction between each one of these groups had a p-value of 0.66. So that is not significant. So even though the droperidol had a trend to faster sedation, it was not significantly different from midazolam or droperidol midazolam. So their primary outcome, the conclusion was that there's no significant difference in the duration of symptoms between these groups. So from that standpoint, you could say, yeah, dealer's choice, take whatever you want. They're equally effective. However, let's take a look at this next slide. And this looks at all of their outcomes. And to give you an idea of where this, the way this works, let's take a look at additional sedation required. So this is each one of these groups. How many of the patients in droperidol needed another dose of sedation? So there were 11 patients in the droperidol group that needed additional sedation, and then next to that you see the proportion. So 33% of droperidol patients, patients getting 10 milligrams of droperidol as the initial dose, needed additional sedation. And by the way, that seems to mirror our response. So 10 milligrams of droperidol, first shot, seems to do the trick about 2/3 of the time. 1/3 of the time they need some additional sedation. In midazolam, 62% of patients needed additional sedation, and 41% of patients needed additional sedation using both of those drugs. If you take a look at some of the other issues, let's look at the one that I think is most significant, drug-related adverse effects. So the percentage of patients getting adverse effects from droperidol, there were 2. 1, 2. 2 drug-related adverse effects. That was 6%. And I'm going to go back here and take a look at one additional slide. And if you look here, there were 33 patients. So look at the droperidol group. 33 patients got droperidol. 11 needed additional sedation. That's that extra little box there. And notice the line going from additional sedation to adverse reactions. That means that none of the patients that got 1 dose of droperidol had any adverse events. All of the adverse reactions came after a subsequent dose of sedation. So the interesting thing about this study is that the subsequent doses of sedating agent, that was not part of the study. So that was unblinded, and it was dealer's choice. Whatever the attending physician wanted to use for sedation, he used. So 33 patients got 10 milligrams of droperidol. 11 of them needed additional sedation. Of those 11, 2 had side effects. Anybody want to care to guess what the drug those 2 patients got? Versed. So the 2 drug-related adverse events in the droperidol group both came with patients getting additional sedation, and the drug was Versed. Well, how many of the Versed, the nice, safe, standard drug, what percent of them had side effects? 28%. So that was actually a statistical difference. So from that standpoint, droperidol was actually safer. And if you look at the droperidol midazolam group, 7%. So 7% and 6% were essentially the same. No big difference there. The other thing that they looked at, since there's this big brouhaha about QT prolongation with droperidol, it's clearly a dangerous drug. It's so dangerous the FDA had to step in and save us from ourselves. There is no black box warning on midazolam. Midazolam is safe in terms of QT prolongation. No warning. Let's look at the percentage. 7% of the patients getting midazolam had an abnormal QT interval. 6 had an abnormal interval with droperidol. So even though statistically that's really the exact same number, the thing I want to point out is that there's no difference between the really dangerous droperidol with the QT prolonging effect and the really safe Versed. So the whole issue about QT prolonging agents was not seen at all in this study. And by the way, all the other studies that look at this show the same thing. This study, or this set of slides, really looks at how variable the response was. And if you just look up at the droperidol group, the y-axis is a scale of sedation. 0 is no sedation. And you'll see up positive numbers, up above 0, are agitation. Numbers below 0 are sedation. What we're aiming for really is 0. We don't want them sedated or agitated. We want them at 0, right in between. We're willing to accept some sedation. We're okay with that. We just don't want over sedation, and we want it to be nice and predictable and even. If you look at droperidol, that's exactly what we get. We get a nice even and rapid dose down towards some sedation and then a gradual rise. If you look at Versed, though, the response is all over the place. Look at how it zigzags up and down. And what that tells us that it is a very variable response. We don't really know how any individual patient is going to respond to it. That's a real problem when we're looking at sedation. So, bottom line, what they found is more patients in the midazolam group needed additional sedation than droperidol. Strike 1 for or against, I should say, midazolam. So I think droperidol wins there. The other thing is that droperidol gave more consistent moderate sedation, and that's a good thing. Versed was highly variable and unpredictable. That's a bad thing. So all of the adverse effects with droperidol came after subsequent doses, and the subsequent doses were with Versed. No difference in QT prolongation. So the bottom line is that, and this is my summary here of this study, droperidol is safe and effective. It provides a more consistent, moderate sedation without any additional side effects. The other thing we noticed is that Versed has a much more variable effect. It has more side effects, more respiratory depression, and needed more rescue medications. The primary outcome is you get equal sedation with 1 dose of both of these. I think, however, if you look at the whole study, what you'll see is even though you're getting even doses of sedation with both, clearly I think if you take into consideration the side effects, the need for additional dosing, droperidol wins hands down. And then I finalized this by showing everybody our protocol, and I showed them why we're using droperidol. All right, well, I will at some point, I think, go over the remaining papers in this study, but I just wanted to do a quick take on why we use droperidol for sedation of violent patients. Thanks a lot, y'all.